Welcome to the Health and Safety Podcast. My name is Michael Wong. I'm the founder and executive director of the Physician-Patient Alliance for Health and Safety. Almost every day on the news, we read reports of opioid-related deaths due to opioid abuse and overdose. However, less attention is given to opioid-related adverse events and patient deaths that may happen in hospital. These opioid administrations are given under the advice and supervision of clinicians, and not because of an individual's actions that may have resulted in an overuse or abuse. This clinical education podcast is made possible by an unrestricted educational grant from Medtronic. I would like to thank Medtronic for their generous support of this clinical education podcast. Through the financial support of Medtronic, the Physician-Patient Alliance for Health and Safety can offer this podcast with full independent control over all programmatic and editorial aspects of the podcast, including selection of clinicians to be interviewed, discussion topics, and questions asked. In previous podcasts, we have spoken with doctors about opioid-induced respiratory depression, including Dr. Jeffrey Vender about respiratory compromise, Drs. Matt Couric and Richard Merchant about procedural sedation, as well as nurses like Barbara MacArthur about monitoring patients during conscious sedation. So today we're talking about hospital pharmacists, about what hospital pharmacists can do to prevent opioid-related adverse events and patient deaths. Hospital pharmacists receive orders to fill prescriptions for opioids from units and doctors throughout the hospital, so pharmacists are in a unique position to prevent potential adverse events from occurring throughout the facility. So we're very pleased to have as our guest Stephen Meisel, PharmMD, who is patient safety expert at the IHI Institute for Healthcare Improvement. Stephen is also director of medication safety at Fairview Health Services in Minneapolis. Steve, could you please give us a brief background about yourself?
Sure. Thanks, Michael. Again, my name is Steve Meisel. I'm a pharmacist by background. I've been focusing on patient safety for the past 25 years of my career at an organization called Fairview. Fairview is a integrated health system with 11 hospitals, 50 clinics, a large retail pharmacy division, home care hospice, and urgent care and retail clinics, and basically the whole nine yards. We're a fully integrated health system based in Minneapolis, and I've been the medication safety director for the last 15 years or so.
Thank you so much, Steve. So IV medications are associated with the highest risk of harm to patients, and opioids are typically considered among the highest risk injectable medications. As the Joint Commission in Sentinel Event Alert number 49 cautioned, while opioid use is generally safe for most patients, opioid analgesics may be associated with adverse events, the most serious effect being respiratory depression, which is generally preceded by sedation. In your article, Increasing the Safety of Analgesia Use in a Community Hospital, you discuss medication errors. What key standards should be implemented to reduce medication errors?
Well, let me first point out that most of the oversedation events that we see, and probably most organizations see, have nothing to do with overt error. So if you look at the universe of medication errors, most medication errors are relatively minor. Somebody might get 2 Tums instead of 1 for a given dose, that sort of thing. Occasionally, you have a large overdose of, say, morphine. You give somebody 10 milligrams instead of 1 milligram, and that's obviously a problem. But most of the adverse events that we see have nothing to do with an overdose like that. They have to do with dose selection in general. It has to do with patient monitoring. It has to do with the unique characteristics of the patient and the concurrent medical conditions. And so when we look at medication safety, we try to look at opportunities to reduce harm, whether it was caused by error or whether it was not caused by error, because the experience from the patient's point of view is the same. If they have an oversedation event, it's not a good thing. Now, when we look at medication errors, I think it's very important to think about it in 3 terms. One is to prevent everything you know how to prevent. And knowing that you can't prevent everything, make sure that whatever does happen becomes visible, so it's easily detectable. So if there is a medication error or there is an oversedation event, that there are alarms, there is good monitoring systems, there are good cues, so that the staff can identify that very quickly. And then the third element of this is to mitigate, so that at that point they can intervene and make sure that the medication error doesn't go on and cause an adverse event, or the minor adverse event doesn't go on to cause a serious adverse event.
Oh, great advice, Steve. Obviously, implementing those standards makes sure that medication errors aren't made or medication errors are caught at the appropriate time so that an appropriate intervention can be made. What have you done to ensure that these standards are maintained from patient to patient so that every single patient is getting the same high standards of care?
Well, that's a very important question across a broad health system such as ours, with hospitals and clinics and retail pharmacies and nursing homes and all the rest. I think it first of all starts with strong leadership and strong culture. From the top of the organization right through through all the rungs of the organization, there has to be a belief that safety is an important value, that it is as important as quality and finance and all the rest. There's got to be good training, good recognition, good rewards, and good expectation setting. It needs to be part of the report and discussions at every level, from the board all the way on down. That's very important. Second is we have to make sure that we implement every known best practice that is out there. And there are lots of them, as you know, from the Institute for Safe Medication Practices, or from the IHI, or from other professional organizations. There are lots and lots and lots of best practices. And unfortunately, way too many of them are just not deployed to the extent that they should be. And so I think it's very important that we deploy all those best practices, and we deploy them in ways that can ensure that they're actually operationalized throughout the organization. So you build them into order sets in your electronic health record. You build them into your pharmacy computer system. You build in forcing functions such as IV tubing that can't be connected inappropriately to an intrathecal line, or vice versa. You have pumps that are different for epidural versus IV and those sorts of things. Those sorts of forcing functions, I think, are very important. But even with all that leadership and culture and those technical processes, that's not enough. I think you've got to innovate. You've got to invent new best practices. What we have learned is that you could deploy everything that's out there, but gosh, you will still suffer adverse events, or your patients will still suffer adverse events. So you've got to dream up new ways of doing business, new approaches to the care of the patients that you're seeing, whatever the condition may be, and identify new ways of doing business. So, for example, in the narcotic world, you want to prevent oversedation events, and one of the risk factors might be that hydromorphone comes in 1 milligram and 2 milligram pre-filled syringes, but the normal dose is about 0.2 or maybe 0.4 milligrams. Well, why would you buy 2 milligram syringes for most parts of your hospital? That's a risk. And so one of the solutions that Fairview deployed for a good decade was to repackage every hydromorphone syringe into 0.4 milligram sizes. And we did that for a decade until a 0.5 milligram size became commercially available. That was innovation. It was inventing a new best practice to try to eliminate the risk of that tenfold overdose that, albeit rare, was always there. And then lastly, you've got to build in adaptive change. Organization with resilience, good teamwork, and communication, so that it doesn't rely upon any one individual person coming to work that day. That there is resilience, so that when somebody doesn't show up, or it gets very busy, or there's a supply shortage, or something, that you build in mechanisms that you can adapt in real time to those circumstances.
So it sounds like you've built in human standards as well as maybe what I call technological standards in having, for example, those pre-filled syringes so that less medication errors can occur. Obviously, something may occur, but it sounds like you guys have minimized that.
We've tried very hard to, yes.
Now, I've often spoken with hospital executives that tell me they don't have an opioid-related problem at their hospital, and yet these same executives will admit to me that naloxone is administered at their healthcare facilities. What has naloxone use experience told you at Fairview Health Services?
Well, it's very interesting. We started our journey on this back about 15 years or so ago. And one of the things that we learned in talking to physicians, anesthesiologists, surgeons, even our vice president for medical affairs at the time, was the same story that you just mentioned, that we don't have a problem here with narcotic oversedation. And then we looked at the naloxone administration and we said, well, gee, we seem to be using an awful lot of this. Mm-hmm. And the response was, well, of course we are, because that's what naloxone is on the market for. People aren't suffering because we have this antidote. And so it is important to change the mindset that the use of naloxone is not a cost of doing business. That it's not a choice of good pain control versus somebody being oversedated or stopping breathing. You can have both. You can have good respiratory function and good pain control, but the use of naloxone is not a cost of doing business. And I think when people say they don't have a problem, it may be because people are not dying or not becoming comatose with long-term central nervous system problems or whatever. But gosh, if they stop breathing and they got given naloxone, that is not something you'd want for yourself or your spouse or your parent, and therefore it is not the cost of doing business.
So it sounds like naloxone really is an indicator that a resort, the last solution resort was given, and that is a problem. You should have been able to do something to intervene prior to that administration.
Absolutely.
So the FDA issued its strongest warning about combined use of opioids and benzodiazepines. What can the pharmacist do to prevent the risks associated with concomitant use of such medications like that?
Well, first of all, keep in mind that if the patient is going to undergo an endoscopy procedure, for example, or a colonoscopy or something along those lines, it is perfectly appropriate and perfectly safe to be administering, say, fentanyl along with midazolam as a cocktail for sedation, for moderate sedation in that setting. So I think we have to be cognizant of the fact that when used thoughtfully and judiciously with good intent and with good monitoring, that's a perfectly legitimate thing to do. Where we get into trouble, however, is where you have somebody who is on post-op narcotic therapy, whether it's a PCA or IV push therapy or whatever it may be, and then they are given a benzodiazepine, perhaps a lorazepam for anxiety. Some orthopedic surgeons like to prescribe diazepam as a muscle relaxant after certain kinds of hip procedures, and then they get given Ambien or something like that at bedtime for sleep. If the nurse isn't really careful and diligent and knowledgeable about what's going on, there's a huge risk of dose stacking, where they get the hydromorphone dose at 2 o'clock, they get the diazepam dose at 2:30, they get both of those at 9 o'clock at night, and then at 9:30 at night they get a dose of Ambien, and before you know it, the patient stops breathing. Mm-hmm. So I think it's very important to be really careful about the doses that are selected, the times that are used in these sorts of things. And what we've done in our electronic health record is to build in alerts so that if two or more of a similar type of drug is given or is attempted to be given too close to each other, the nurse will get a pop-up warning that says, think twice before you give this.
Mm-hmm. And obviously, as the hospital pharmacist, you're seeing all these orders coming in, and as you say, you can see when dose stacking is occurring. You've also mentioned monitoring, and does Fairview Health Services continuously monitor its patients receiving opioids or other sedatives?
Well, certainly in the post-op setting, I mean, if a patient is in for a pneumonia and happen to have a sprained ankle and have a PRN dose of Percocet, we're certainly not going to do any special monitoring in that setting. Mm-hmm. But in the acute post-op setting, we require that any adult inpatient who has an order for a narcotic undergoes a continuous capnography monitoring for the first 24 hours after the surgery, and then longer depending upon if the patient is doing well or poorly or whatever. And then we also apply continuous pulse oximetry in that setting as well. So they have both continuous pulse oximetry plus capnography for the first 24 hours after surgery for all of our adult inpatient patients.
And so who can make those requests? Is this a physician order, or is it something that an RT, a nurse, or you as a pharmacist can do?
Well, we've, again, going back to the forcing function idea, mm-hmm. We have built that into our order sets. So, no, a nurse can't just order one of these. There needs to be a doctor's order. Mm-hmm. But we have built it into our order set so that all of our post-op pain orders have pre-checked boxes for that level of monitoring. So the doctor doesn't have to do anything. In fact, he doesn't even see the order. He could, but he generally doesn't see the order. And it goes through as soon as he signs them. And then the patient is on that type of monitoring for that time frame that I mentioned. So no, a nurse can't order that monitoring. Only a doctor could, but we've forced that as part of our post-op order sets.
Yeah, well, it sounds like a great thing to have these order sets in place so that people just don't forget what needs to be done or what has to be done to make sure that the patients are safely taken care of.
Yeah, absolutely.
So any last words of advice you would give to clinicians and hospital executives wanting to improve opioid safety in their hospitals?
Well, I think the first piece of advice is to recognize that there is a problem. Just like the alcoholic can't change his ways and get better before he admits he's an alcoholic. Mm-hmm. The hospital can't reduce its risk for narcotic oversedation until it believes that there is a risk for narcotic oversedation. So that's the first piece. There is to recognize that there is a problem. And that there is at least there's a risk. So that's the first thing to do. The second is to make sure that there is somebody who is in charge of this. Somebody is appointed to be the point person, to look at the data, to review whatever naloxone administrations are given, identify the risk factors and the commonalities and all of that, and to begin to identify what changes ought to happen, whether it's in monitoring or prescribing or dispensing or whatever it may be, that would help improve the situation. Third is to measure. You can't improve what you can't measure, at least not very well. So what we have for the last 10 years or more, we have a run chart every quarter where we have the number of narcotic-related adverse drug events plotted over time by hospital and as an aggregate, and we post that regularly. It's reviewed by our pain committee. It's reviewed by our pharmacy and therapeutics committee and others. And so we have that measured, and we know whether we're getting better, staying the same, or in some cases at times getting worse if that's the case. So you've got to measure. I think that's very important.
So in your measurements, have you seen, since putting in place these standards and other practices, seen a decrease in the number of adverse events or unfortunately tragic patient deaths that may have been occurring?
Well, we have not, thankfully, had any patient deaths, at least not in any recent time. But I can tell you that, yes, we have seen an impact on narcotic-related adverse events. In fact, at our university hospital alone, from 2008 through 2016, we had an 82% reduction in our narcotic-related adverse drug events.
Wow, that's amazing.
82%. It's not zero. But that's an 82% reduction over an 8 or 9 year period. So I think that's very, very telling. And it shows that this is something that you've got to be at for the long haul, but you can make a difference.
Yeah, absolutely. Absolutely. So thank you so much for joining me on this podcast. And hopefully, clinicians and hospital executives out there will listen to this, and particularly your advice to be aware of the problem and then to construct systems around solving that problem. So thank you so much for joining me in this podcast, Steve. This clinical education podcast is made possible by an unrestricted educational grant from Medtronic. I would like to thank Medtronic for their generous support of this clinical education podcast. Through the financial support of Medtronic, the Physician-Patient Alliance for Health and Safety can offer this podcast with full independent control over all programmatic and editorial aspects of the podcast, including selection of clinicians to be interviewed, discussion topics, and questions asked.